Hello, everyone. Welcome to the University of Toronto's Joint Centre for Bioethics seminar series for the 2022-23 academic year. I'm Erica DiRuggiero, and I'm the Director of the Centre for Global Health and an Associate Professor of Global Health at the Delaware School of Public Health, and it's really my pleasure to be moderating today's seminar. And it's also my pleasure to announce today's seminar is co-hosted by our Centre for Global Health. We're really thrilled to have today's speaker with us. Jake Okechukwu Effoduh will be presenting on tackling bias in health AI systems from a human rights lens. So welcome, Jake. The format of today's seminar is a presentation by our speaker, who I'll introduce in a moment, followed by a moderated discussion with all of you. The seminar is being recorded, and it will also be posted on the Joint Centre for Bioethics website, where you can also view other archived seminars in this series. But before I introduce Jake, I would like to take a moment to acknowledge this land upon which the University of Toronto operates. For thousands of years, it's been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. And I would encourage all of you, depending on where you're joining from, to take a moment to acknowledge the land on which you're joining us from. And so now it's really my pleasure to introduce today's speaker. Jake is a Vanier scholar and a PhD candidate at the Osgoode Hall Law School. His doctorate research is examining the ways that the legitimization of AI impacts the pursuit and realization of human rights within three key African countries, Nigeria, Kenya, and South Africa. And his work also investigates if the technology will solve or exacerbate the popular legitimization crises that human rights activist forces within the region currently face. He's also the Chief Counselor of Africa, Canada Artificial Intelligence and Data Innovation Consortium, or ACADIC for short. And ACADIC mobilizes AI and big data techniques in an ethical way to build resilient governance strategies and increase societal preparedness for future global pandemics and other public health concerns. Jake also serves as the human rights compliance personnel and ethics advisor for this consortium. Jake's also been an international human rights lawyer of 12 years with programmatic experience from working across Canada and 28 African countries. He holds 2 master's degrees in law from the University of Oxford in the UK and from York University here in Canada. He also serves on the World Economic Forum's Global Future Council on Frontier Risks, working with a team of experts to identify key future shocks for the next generation and propose policy opportunities that will build resiliency in the face of global health risks and other frontier risks. So really delighted to have you here, Jake. So after we hear Jake's presentation, we'll have a chance to hear your questions and your thoughts. I would encourage you to put your question into the YouTube chat. And if you're not logged into YouTube or wish to ask a question anonymously, you may also send your question to jcb.ea@utoronto.ca. And this email address will be posted in the chat for you, for those of you who are also joining via YouTube. So I'm going to now invite Jake to offer his presentation and then look forward to hearing all of your questions and to participating in the discussion. So over to you, Jake, and thank you so much for joining us today.
Thank you very much, Erica. I'm really honored with your introduction, and thank you for the great work you do as Director for the Center for Global Health. I am indeed very happy and excited to be engaging with you all at this JCB Bioethics Seminar Series, which is co-hosted by the Center for Global Health. I would also like to thank Professor Jay Shaw, who is the Research Director, AI Ethics and Health of the JCB. Thanks for inviting me to this series. And thanks to Vadim Levin and Terry Yuen and every other person who has sort of worked to put in this series together. Most importantly, thanks to everyone who's joining, despite the difference in time zones. I hope that this would be a great discussion and a valuable seminar. I must commend the Joint Center for Bioethics for putting together such a great series that provides a free public platform for very important bioethics discussion. So I will share my slides now, and we can begin to talk. So today we're going to discuss how to tackle bias in health AI systems, but from a human right lens. So I'll be presenting for about 50 minutes, and then we'll have about 15 minutes or thereabout to discuss and engage with your questions. So this is more of an engagement, not necessarily a lecture. I would like it to be a conversation. Feel free to contribute, use the the chat box, share your ideas, and of course, bring in your questions. So as an introduction to this topic, the healthcare industry is witnessing an era of innovation explosion, part of which is as a result of the increased use of AI within various healthcare contexts. Now, although the use of AI is still relatively new, there are already promising examples of AI systems that are improving diagnostics, treatment, speed of healthcare delivery, name it. We have the use of AI systems that can remarkably predict disease outbreaks, can predict heart diseases even before any signs or symptoms show. So clearly the use of AI is advancing, the practice of telemedicine, the practice of drug research, clinical operations, name it. And many of these innovations are unprecedented. However, one of the biggest challenges is the use of AI and the ways that it may perpetuate bias. So as a maybe soft definition, this is pretty much an instance where the application of an AI algorithm would result to compounding existing inequities, which could be, maybe an AI system might racially be biased, or, might maybe undermine a person because of their disability or sexual orientation or religion or background in a way that adversely impacts their rights to healthcare or their ability to access healthcare systems. We will talk about the various ways by which this phenomenon could happen. But I will start with sharing a bit of my experience. But I think one of the many ways that this could happen is when an AI system, for example, is systematically prejudiced because of the false assumptions or erroneous assumptions that have gone into the machine learning process. So I would, tell you how, speak about bias in health AI systems. I will discuss how AI systems can become biased, how they enter the systems, and the harmful effects that they have. But more importantly, I'm going to use a critical human rights approach to explore some of the legal and regulatory responses to bias for AI in health. So I'm going to start my conversation with a personal experience just to kickstart the conversation. This is a story of mine, and I'm sure many of you have your own bias experience with the use of AI, perhaps not in healthcare. But this was a conference in 2018. It's called the Annual Meeting of New Champions Conference. It was the foremost conference for tech and AI. It's where literally the world meets in Tianjin, China. So really brilliant, technological innovations. And right here, as you can see, I'm holding a microphone in my hand and I'm speaking to this AI system. The AI system has no camera, it's just a recorder. And you speak to it for 1 minute and it does literally a lot. It will tell you your weight, your height, your age, if you have any cardiovascular problems, if you're suffering from lung cancer. It will tell you if you're tired, if you're awake, if you need hydration. So it's mind-blowing, right? How do you speak to a system and it's able to tell some of these things? The way that it does that is that the technology uses, it's collecting data like your voice, but more importantly, it is dissecting that data by taking cognition of your aphonicity, your coveredness of your voice, the breathiness of your voice, the flutter of your voice. It's looking at the glotalization of your voice. There's so many things: the pulse, the resonance, the roughness, the tremor, the loudness or not loudness of your voice, the yawniness, the what. There's so many things, up to 150 things the system is collecting. How it connects that to lung cancer or cardiovascular issues is a different conversation completely. But beyond the health dynamics, this system is also able to predict your height, your age, your weight, your sexual orientation, your general state of your health, if you have a neurological problem, your skeletal structure, as you can see in the picture there. Interestingly, the system was able to get all of these things correctly. It said I had no muscular or psychological or neurological problems. So I was like, oh, thanks. I took that and I was happy for that. But it failed. It was biased in one area, and it was the most significant, most apparent area. The technology did not tell that I am Black. So when it described my skull or my skeletal structure, it says I am Mongoloid instead of Negroid. And you can tell, of course, the conversation went into, okay, what happened? Why did that happen? But I just shared this story to show you how phenomenal an AI system in health can be in terms of helping us dissect and diagnose certain things. But it could be heavily biased, not only in the things that we can't see, but it's biased at the very most apparent thing that is very clear. In the course of this seminar, you're going to find out why that happens, but we're going to do this in 4 different parts. I'll start by a little ontological consideration around artificial intelligence, not to minimize the knowledge of everyone here, or just so that we foreground ourselves with what is artificial intelligence? How is it defined? And why is it difficult to define, actually? But how is it defined in computer science, in healthcare and law? Then in part 2, we're going to talk about the biases in health AI systems. And basically, we're going to look at what is algorithmic bias? Where do they come from? How do they get into AI systems? What are the reasons or results from bias in health AI? And then in part 3, we're going to also do a little bit of a foregrounding. I know we all know what human rights are, but we'll speak a bit about the recognition of health rights as human rights, how health rights are affected by AI. And then we're going to talk about human rights from the human rights issues from bias in health AI systems. And the last part would be where we're going to think about how do we solve the problem of bias. And I'm going to propose some of my human rights framing. But before that, I'm obviously going to lay the ground in terms of explaining the ethical governance of health AI from a bioethical perspective. I will share some of the law and regulatory responses, some technological responses as well, and then I will share some of my human rights framing in that regard. So we're going to go to part 1. Let's talk about why defining AI is hard. I'm going to be quite brief on some of these things because I believe most of us already know how it's defined in computer science, in healthcare, in law, but there are some interesting things that I think would be worthy of note. Now, artificial intelligence is very difficult to define because it's a misleading term. I would say it's misleading because sometimes it's difficult to define what you mean by intelligence, right? Some people say AI is pretty much the application of narrow inference tasks, where you just bring large volumes of data and you present them with good processing power and find some associations with them. And I know ChatGPT might make you disagree, but AI is not yet a general purpose replacement for human intelligence or ingenuity. Another reason why it's hard is because AI is a loaded construct. It relates to more than 23 disciplines. It is both a recent technology of fourth industrial revolution. It's also an abstraction. It has existed for over 100 years, but it's also a recent buzzword today. So on some hand, it's a system. On some hand, it's part of a system. On one hand, it's a system of its own. So it's a very loaded construction. In law, we agree on what is considered artificial, but we are not fully in agreement of what is considered intelligent. Can a non-biological being be intelligent? Is ChatGPT intelligent? Not every plant or animal is even intelligent. Talk more of a math or a computer program. The goalpost for what is AI keeps shifting, right? Calculators were once considered AI in the scientific community, but now it's not. So I think people say whatever a computer cannot do today would be AI tomorrow. And then when we're talking about what is AI, especially when we discuss health AI systems, there's a lot of context that must go into it. In health AI systems, the bar for what is AI is a bit higher. The AI system must be able to either carry out some form of diagnostic function, some treatment function, or maybe speed up the health delivery of some way, right? So, in the health field, machine learning must be used for it to gain that status, of AI. But Yes, we know that the history of artificial intelligence comes from the origins can be traced back to the 90s, to the 50s, with like people like Alan Turing, the British mathematician, who literally questioned the ability for machines to be able to think. So the Turing test implies that a computer passes the intelligence test if a human being interrogating with that computer is unable to tell if they're communicating with a fellow human being or a machine. 6 years later, after that notion, John McCarthy here at MIT sort of organized a conference in Dartmouth. And then they agreed that, AI would be anything that can think like a human being or think rationally or act like a human being or act rationally. Now, the reason why it's important to understand a little bit of this history is that one of the first areas where AI was applied in the history of the world was in medical diagnostics. Right? From that workshop held in Dartmouth College in like 1956, there were a handful of scientists who decided to think about the possibility of creating an artificial brain. So the earliest work for medical AI dates back to some of those constructions. It's important to recognize how it wasn't necessarily just a computer science that this came out from, but literally the discussions around molecular biology through the dendritic algorithms. So some of those constructions is what informed AI as to where it is today. In healthcare, AI is used as an umbrella term to describe the application of machine learning algos and other cognitive like technologies in the medical setting. We'll talk a bit about more of this, but in international law, which is my field, I know we talk a lot about bioethics, but there's a very strong correlation between the ethical principles of use of AI and the legal principles as well. So in law, there is no widely accepted definition. We still very much query if AI should even be called AI. But the basic locus of understanding AI within international law has been the use of its algorithm. So we go down to we call it the locus. We'll go down to the fundamental ingredient of AI systems, which is pretty much the algorithms, right? So we all know what algorithms are. These are pretty much step-by-step procedures for solving a problem. For example, if you go on one of the health websites in Canada to check if you've done your COVID test, the algorithm used in the system would check, have you done your COVID test? If you click yes, the next set of questions will roll. If you click no, a different set of questions will roll. How many doses? Have you gotten your booster dose? And then if it gets to the point where it needs to trigger to call a customer service agent. So this is a typical example that the algorithm itself, those set of rules to be followed to solve a particular problem, is where the law situates the beginning point, for AI systems. So generally, it's possible that there is no one standard definition of AI, even a wanting definition, or even any definition you give may need to follow some descriptive or theoretical or practical evaluation. But when we talk about AI in medicine, it's a lot more specific, especially in the ways that it's used to either provide healthcare or in the ways that certain human beings engage with them in various medical settings. Now, I'm not going to bother you with the hierarchies of AI, like the meaning of AI, machine learning, and deep learning, but I have a few examples of some of the health AI systems that currently exist. So Hero AI, I've heard about this from, I think, the co-founder and CEO. His name is Devin Singh. He's one of Canada's first physicians to specialize in clinical AI, and he practices in pediatric emergency medicine. So Hero AI is an AI software or system that helps children in terms of accessibility to services and in their treatment as well. Ubenwa is another example of a very fascinating AI system that actually uses the sound of babies when they cry. From the sound of the cry, it can identify if the child has some neurological or respiratory condition, right? UPA is pretty much an assistant for mental illness. It helps to facilitate empathetic or compassionate interactions, and it also helps with mindfulness activities. So it's important to see that the use of AI in healthcare ranges from pediatric medicine to mental health intervention. Happify also it helps people deal with mental health issues by providing them with games and other activities from a digital AI instructor. There's also a nursing assistant, a virtual nurse, which this AI nurse actually visits the patient once or several times in a day. And so there's an avatar that can request that the patient, examine vital signs. It can check out the patient's weight or blood pressure. And then there's MD Acne, which I sort of stumbled upon on Instagram. I was like, okay, what is this? They promoted it on Instagram and I sort of read about it. It connects users to dermatologists absolutely immediately. So it can take a scan of your face and can tell you a treatment plan that you need. And it can do this in like less than 10 or 15 minutes. And then there's, Care Score, which helps patients with their vital signs as well, especially when they're not in the hospital, right? So there's so many examples in terms of how AI is being used. Some of them are like machine learning systems. Some of them are deep learning systems. And we can talk a bit about that if you want to know the distinction between them. So we've tried to describe artificial intelligence, describe, how it's been defined, and some examples in the way that they're used. But when we talk about bias in health AI systems, what exactly do we mean by bias? Where do they come from? How do they get into health AI systems? And what are the impacts? So quickly, in terms of defining what algorithmic bias is, so really, there's so many definitions, but it's pretty much when a scientific or a technological decision is being made from a narrow set of concepts. For example, if a technology would privilege certain groups of people and harm other groups of people, then we can say that that technology is biased, especially if it's developed to cater for literally everybody. So this can occur when an AI algorithm produces results that are maybe not representative, or the system is prejudiced due to so many reasons we're going to find out very soon, one of which could be an erroneous assumption in the machine learning process. So algorithms are mostly assembled according to the instructions made by people, right? People are the ones who develop the systems. People are the ones who train the systems with the data. So bias in health AI occurs when the results cannot be generalized widely. The picture you can see here is an exploration into the fallout of an MIT Media Lab researcher. It's pretty old, but Joy Bulwamini, she discovered racial bias in facial recognition algorithms. So the Ghanaian American, she calls it coded bias, shows a massive way by which the AI did not recognize her face, but when she put on a white mask, it did. So in her explanation, she was saying that the AI system was actually considered to be used in certain hospital settings, whereby it can scan your face and then obviously all your data sets would show up, or it would help the doctor speed up health provision. But if the system only sees white faces, how then can it see diversity or understand the various people that would use it? So I have a quote here from Panch et al. It says, instances where the application of an algorithm compounds existing inequities. And this could be race, it could be your ethnic background, it could be your socioeconomic status, it could be your religion, your gender, it could be because of your disability or your sexual orientation. And I think no one is immune from the effects of bias. It doesn't some AI systems could disadvantage white people, some could disadvantage women. Nobody, as long as you have a race, as long as you have some ethnic origin, as long as you have an identity strand, you are liable to to face some form of bias, and hopefully not. So we often think of biases only resulting from preferences or exclusions in the training data. But bias can also be introduced by how the data is obtained, by how the algorithm is designed, or by how the AI outputs are interpreted, right? So Vivian Ming says a lot of times the failings are not necessarily AI. The failings are literally human failings. As humans, we all have biases. And so why do we expect systems to not have biases? Yes, there could be a lack of diversity in the teams that build the AI systems. Or it could be more, right? So there's so many reasons as to how these biases happen. And I'll try to explain in some ways how the biases get into health AI systems. So psychologists say that there are about 180 cognitive biases, maybe more. But the world that we live around people with different perspectives and different experiences. Certain people are predominant in certain areas, and and certain people are not. So the world doesn't work on an equal footing. There's just a lot of diversity and a lot of complexity. So when we collect data, because data is what some of these AI systems are trained on, when we collect that data, the bias would go into that data set. It could be historical in the sense that a certain class of people have always been the one understudied for like AI systems. It could be a measurement bias, which is pretty much a systematic distortion in the result of treatment comparisons between various measuring outcomes. So when healthcare providers or researchers or study participants have only secluded or not measured adequately, the system definitely the data definitely will carry some bias. It could be temporal bias. So from the data, it could be historical, it could be representational in the sense that you don't have enough women, you don't have enough queer people, you don't have a lot of people who are living with disabilities, you don't have a lot of Black people. And again, the solution is not to do where you have like 20 white people, 20 Black people, 20, like when I've had conversations about bias, it doesn't work that way. It needs to be, and we can talk about that, it needs to be representative, but more importantly, that representativeness needs to be articulated in a way that anybody who uses the system would recognize them in a way that does not disadvantage them from other people. It could also be a temporal bias, which is pretty much where you assume a wrong sequence of events to someone's illness. So when people collect data, certain things lead to certain people's illnesses. Some people, maybe because of their lifestyle, they might be prone to diabetes, but some people, it could be genetic, right? So if there's a wrong sequence of events, it could lead to a misreading about the reasoning of someone's like causality, for example. It could also be an omitted variable bias. And I think this occurs in health statistical models where you leave out one or more relevant variables. So the bias results in the model like attributing the effect of that missing variable to those that were included. So let me see if I can give an example. So in healthcare, for example, the age of a person, I'm talking about the omitted variable bias right now. The age of a person is many times negatively correlated with their ability to be like a donor, like a sperm donor or a blood donor or a bone marrow donor, right? The older they are, the less likely they will be considered for like a bone marrow donor. And maybe even negatively correlated with the strength of their immune response. But the age of a person could be positively correlated with their resilience levels, So in terms of how this data is collected, omitting the variable age in your regression result there's an example here, could actually affect the data set in a way that even though you were not considering age, it could affect treatment plan outcomes. So you see, from the world, the bias gets into the data, and then the data sets used to train the AI or machine learning systems could pretty much, repeat certain errors. It might just like literally just repeat what is already existing in the world, or it could exacerbate in a way that it creates unfair outcomes, such as privileging one arbitrary group of users over the others. And in that category, you would see they're like algorithmic bias, evaluation bias, aggregation bias. I could speak a bit about what some of these things mean. It could be popularity bias. For example, let's go to evaluation bias. This is pretty much an unfair evaluation of a person's disease, right? Aggregation bias could be the expected difference between, say, the effect of a group reaction to a drug and the effects for the individual reaction to the same drug. So because certain people have different ways that their bodies respond to certain medications, the fact that most people respond in a certain way, the AI system may just subscribe a minority person who doesn't like respond in the typical way, right? So that's there's an aggregation bias in that regard. Popularity bias is simple. Pretty much items that are overly exposed in recommendations are seen to be used by most people in healthcare settings. So you see, there are many. Even when I talk about linkage bias, it's pretty much the origin of the bias. It's not necessarily bias in itself, but it's the mechanism of it. But this is just to explain to you the different types of biases and the different ways that they come into these systems. From the world to the data to the machine learning algorithm to the point where it gets to human review, there are also other issues to consider. Mind you, healthcare settings already deal with bias even where there is no AI systems. But when the AI systems come to play, sometimes people just like maybe completely use the technology without recognizing the disparities in individuals. Or from a behavioral point of view, there might be like irrational beliefs or behaviors that can, unconsciously influence decision-making processes, right? So it could be an emotional bias, it could be cognitive as well. There's also the issue of like social biases where you just assume that maybe because a person is older, then they're weaker, or that because the person is a man, they can actually endure pain more than women. So there's so many AI systems who have like assumed some of these things, or they're assumed as they're being used like within AI systems. Or it could be social biases, which pretty much includes different forms of discrimination. Certain people already suffer because of their gender identity or because of their race. And, there's more to consider in this regard. So I took time to explain this so you understand that the biases don't only come from the systems. The biases come from the world that we live in. It could come from the data. It also come from the review, how we review the systems, but even how we act on these AI systems. So in summary, biases get into AI systems in three ways. It could be from the data, the origin of the data. Who generated the data? What system did they use to generate the data? Is the data representative? Does it take people of all ages, languages, races? For example, an AI system that was used to help some pregnant women to predict their birth didn't use women of a certain size. And so therefore, the system became biased to women who are much bigger. The same way some self-driving test cars did not consider children living with disabilities. And so therefore, their testing failed. So it could also come from the people, and not just people who design the system, but people who fund or people who regulate AI systems. For example, of the 25 most funded AI startups, which literally grew from like 3 billion in like 2013 to nearly up to 75 billion today. And so funding increased like exponentially, right? But most of these startups are based mostly in US and China, nabbing over 80% of all the investments. So you see only specific countries are advancing in this regard. In Africa, for example, interestingly, 4 countries, Nigeria, South Africa, Kenya, and Egypt, are the 4 countries that actually have access to 95% of the funding when it comes to health AI startups. The remaining 5% is for the other 51 African countries to share. And so it's important to recognize that there's also there's a disparity in terms of the funding, the designing, but also in terms of who gets to source or train these AI systems as well. And it could also come from the technology, which can actually be from cognition or from the way that the technology is introduced or it's deployed, right? So in this video, it's just give it like a little background. United Health Group's Optum division, which is an organization that has done really great work, but they were unaware of the bias in the data that they used to like develop a product market. This product market system was sold to so many hospitals in the US, and the algorithm actually used past spending data of various patients to predict the severity of their illness without thinking of other societal factors. So it looked at, okay, if people spent more money, it means that they were sicker. Or if they spent less, it means they were like healthier. But less money has been spent historically on Black patients, but again, we're going to watch the video now. It's just about 4 minutes, and it explains a very important point about racial bias within healthcare settings and the implication it can have.
A recent study published in Science magazine found significant racial bias in an algorithm used by hospitals across the nation to determine who needs follow-up care and who does not. Megan Thompson recently spoke with Stats Shraddha Chakradhar, who explained what the researchers found.
Where exactly was this bias coming from? There are 2 ways that we can identify how sick a person is. One is how many dollars are spent on that person. The assumption being the more healthcare they come in for, the more treatment that they get, the more dollars they spend, and presumably the sicker they are if they're getting all that treatment. And the other way is that, we can measure actual biophysical things, from lab tests, what kind of conditions or diseases they might have. So it seems like this algorithm was relying on the cost prediction definition. In other words, the more dollars a patient was projected to spend on the part of an insurance company or a hospital, then that was a sign of how sick they were going to be. And that seems to be where the bias emerged.
I understand that the researchers then sort of reuse the algorithm using a different type of data. Can you just tell us a little bit more about that? What did they use?
Yeah, so instead of relying on just costs to predict which patients are going to need follow-up care, they actually used biometric data, biophysical data, physiological data, and they saw a dramatic difference. In the previous model, the algorithm missed some 48,000 extra chronic conditions that African-American patients had. But when they rejiggered the algorithm to look more at actual biological data, they brought that down to about 7,700. So it was about an 84% reduction in bias.
Do we know anything about how the use of this biased algorithm actually affected patient care?
We don't actually know that, but as I mentioned, the algorithm is used by hospitals to help them flag patients who might need extra care in the coming year, whether it's, an at-home nurse or making sure that they come in for regularly scheduled doctor's appointments. So we can only presume that if sicker Black patients weren't being flagged accurately, that they also missed out on this follow-up care.
Are there any consequences for the company Optum that was behind this algorithm?
Yeah, so the day after the study came out, actually, New York regulators, the Department of Financial Services and the Department of Health sent a letter to the company saying they were investigating this algorithm and that the company had to show that the way the algorithm worked wasn't in violation of anti-discrimination laws in New York. So that investigation is pending. One encouraging thing is that when the researchers did the study, they actually reached back to Optum and let them know about the discrepancy in the data. And the company was glad to be told about it. And I'm told that they're working on a fix. The other encouraging thing is that the researchers have actually now launched an initiative to help other companies who may be behind similar algorithms to help them fix any biases in their programs. So they've launched a program based out of the University of Chicago's Booth School to do this work on a pro bono basis so that they can sort of catch these things in other algorithms that might be used across the country.
All right, Shraddha Chakradhar of STAT.
Okay, sorry for the long video there, but I think just the last statement that was made, I think that is the value of what the JCB is doing. The really important value of bioethics when it comes to dealing with issues of bias in health AI systems, right? Especially because they said, the law was like, well, they did not violate any anti-discrimination laws. So sometimes it's not really about the laws of how I've checked the law and I've fulfilled it, my system has been approved, but it's also the ethical constructions. We could speak a bit about why they use a cost prediction analysis, which makes some sense, but two things are important here. One is something we call data triangulation. I felt like if they had used biophysical data and physiological data with the cost prediction analysis at the very onset, they would not have gotten to the point where they will miss up to 48,000 chronic conditions that Black patients were facing. One good output, like the speaker mentioned, was how they were able to rejigger the algorithm and they got an 84% reduction in bias. And I think as we speak, I would talk a bit about how the algorithm can be rejiggered, like the value of debiasing orders, as we call it. But you see, some of the reasons are very clear as to why this happens. I think there's a lack of clear standards on fairness. If you Google doctor, for example, you're going to see more pictures of men than women. And so these systematic inequities are embedded not only in societies, but in health systems. So it's difficult to define what is the standard of fairness, what is the standard of like adequate representative data, because algorithms are trained on data from the world, which is what creates that need for additional stewardship, right? So the standard of fairness is still not very clear. There's also a lack of contextual specificity. Health systems vary in the way they're designed, in the various objectives, and the diversity of groups of people that they serve from different cultures and environment. So, different profiles, different preferences, different genetic endowments. So a generally applicable AI model must be developed in a way that reflects this very rich diversity. And then, of course, there's the issue of the black box nature of like deep learning algorithms, right? So deep learning involves the transformation of data from the real world. For example, if you look at deep learning in reading X-rays, right? It would pixelate the X-rays and read into multiple layers of numbers to combine and create some outputs when it comes to like a diagnostic like reading. So they're up to like 100 layers. Sometimes a human eye cannot see, but a machine can use a Bisonite process to yield different kinds of powerful results. But it's very difficult to establish. So when data scientists or clinicians or patients, if they want to know how exactly did the algorithm tell that my lung or my liver has this particular issue, there's not some adequate explainability to that regard, which is what like the black box nature, of course, deeply contested in the literature. But in terms of what this leads to, so many things. Of course, diagnostic errors from the example we saw. And there are other examples as well. There's an AI technology that was used to detect skin cancer and excluded people of color and misdiagnosed them. So there's a problem of misdiagnosis. There's also a problem of inequitable access to healthcare services. There's a US AI health system that reduced the number of Black patients receiving extra care by more than half because the system was not used to having that many Black people within the medical space. There's also an example in Uganda where a Chinese health AI system deployed in Uganda asked people to select their sexual orientation, and if they selected anything else but straight, they were removed from the system and unable to register. So there's also the issue of death, which could result from misdiagnosis or like drug maladministration. So these are some of the results of what biases in health AI can come to. So I'm guessing with part 2, we understand what biases are. We understand how they come from, how they get into AI systems. We understand the impact in terms of what it can cause, not only to the health system, but also to individuals who need to access care. Right now, we'll go to part 3. I'm going to speak a bit about the human rights and health AI. Briefly, what are human rights? Where do they come from? How are they recognized in law? And how health rights are affected, by artificial intelligence, and some of the, human rights issues from bias, in health AI. So we know what human rights are. They are standard norms that, enforce the values of dignity, freedom, equity, and accord. It is pretty much what every human being should enjoy. We're inherently entitled to it. These rights are, interrelated, interdependent. We need them all together. You cannot tell me that I have a right to life, but I don't have a right to water, or that I have a right to water, but I don't have a right to health. So you see, they're interdependent. And I'm not going to bore you with the literature around the generations of rights. Now, in law, human rights are recognized not only domestically, but also globally and perhaps regionally as well. So in Canada, there is the Canadian Human Rights Act of 1977, which is a statute passed with the express goal of extending the law to ensure equal opportunity to individuals who may be victims of discriminatory practices on a set of prohibited grounds. There is also the Canadian Charter of Rights and Freedoms, which is published as part of the Constitution. It sets out the rights and freedoms that Canadians believe are necessary for them in a free and democratic society. So it's a part of the Canadian Constitution. And of course, it enforces your democratic rights, your mobility rights, your legal rights, equality rights, and all. It does not specifically speak about your right to health, But I think people sort of relate the interrelatedness by saying, if you're telling me I have democratic rights and I have a right to life and a right to like dignity of my person, I definitely should have a right to health, but it doesn't really specify that. But importantly, the right to health is recognized by both domestic and international law. We have the International Covenant on Civil and Political Rights, the International Covenant on Economic, Social, and Cultural Rights, a couple of international laws, and the Universal Declaration of Human Rights, which is the most cited, most important international document when it comes to human rights, actually drafted by John Humphrey, a Canadian lawyer. He played a role in drafting the declaration, and he listed out 30 articles, which speaks about, freedom, equality, and it's the most cited document across the world. So when people talk about the right to health, they're also talking about their right to, to enjoy their well-being. They're talking about the right to access health services without any form of discrimination. But it's important to note that the right to health is not the same right. It's not the same as the right to be healthy. But it doesn't also mean it's only a programmatic goal. It actually needs to be attained in the long term. So there are other laws in Canada as well that enforces or recognizes the right to health, even though Canada's federal legislation is pretty much a publicly funded health insurance care. So there are criteria and conditions related to insured health services and extended health services that that certain people can have access to. So how are these health rights affected by AI? Because we're using a human rights lens to look at how bias can be resolved within health AI systems. Now, there are two things that happen. When health AI systems are used, they could either augment health rights or they could diminish health rights. So it's, on so many regards, the use of AI in healthcare has advanced the right to health by improved diagnosis, improved clinical care, enhancing health research, drug development, assisting with the deployment of disease surveillance. So part of my work with ACADIC, as Erica was explaining earlier, ACADIC is the Africa Canada AI and Innovation Data Consortium. What we've done in terms of using AI to augment health rights is we developed COVID-19 monitoring dashboards that actually visualize locally relevant information to the public and to government, right? So these dashboards that we created in Canada became official dashboards used by policymakers in Botswana, in Nigeria, in Eswatini, in Mozambique, in Namibia, in Zimbabwe, in South Africa. So AI is able to help in terms of analyzing disease surveillance and in some regard predicting where the outbreak would have much stronger impact or less stronger impact. We've done the same with monkeypox. We're doing one right now with malaria, but the COVID-19 one was the one that really a lot of African governments sort of relied on. But on the other hand, there are ways by which, and of course, in our work, we try to see, and that's my job, how do we pinpoint areas whereby the system may be biased, right? And then, we can talk about that when I'm discussing the human rights approaches. But on the other hand, the use of AI can diminish health rights in a way that it could expand the digital divide on access to health. It could undermine human autonomy. It could increase biosurveillance that affects the trust or privacy of individuals, right? And I can give some examples. In 2019, for example, research done by the USAID showed that the bias in an health AI algorithm affected response to HIV programming because the AI system relied on those very scary dystopian accounts of HIV that was driven by fear in the 80s, where they would be like, oh my God, it's a death sentence. But the AI system is not a human being. So it literally just perpetuated fear on people who were using the application, right? Another example is Apple's Health Kits. The first release did not include a menstrual cycle tracker because I think maybe there were no women in the development team. So they did not think about menstrual cycle as one of the health tracking options that would be used in the health kit. And there are other wearables as well who have had so many issues. I remember when the Apple Watch started, it was very difficult to measure the light reflectance from darker skinned people, right? And in 2020, there was an algorithm that was used to select nursing candidates. And in South Africa for a multi-specialty practice, and they selected only white females. They kept trying to rejigger the algorithm, but the algorithm just kept doing the same thing over and over again. So there are so many examples in this regard around ways that we can say, yay, it's doing us well for health rights, and places that we can be like, yay, it's not doing the same. So let's solve this problem of bias. People have asked me, is it solvable? Can we solve the issue of bias? I don't know. I don't want to, it's a tough question to answer. It's like asking, can we as human beings, can we remove the biases that people have? Can we remove the biases in institutions? I think we can mitigate the effect that the effect of biases from health AI systems. And I think the technology can at least maybe do better than human beings would. But more importantly, I think it's teaching us some of the things that we're supposed to know, and it's showing light on ways, on issues that we didn't take into cognizance before. But anyways, I will start by just running through some of the ethical governance of health AI. We have the WHO guidance, which is a brilliant 150-page document released in 2021 by the WHO. It was like 18 months of deliberation. They got a lot of like bioethicists, like medical experts, clinicians, lawyers, human rights activists into working on this for a long time, and they produced that. We would explore what that guidance provides. I would share some legal and regulatory responses to bias in health AI, because the law though needs to be revamped, but there are some legal responses to bias in health AI systems. We could talk about a few technical or technological solutions, and then I would share my 7 propositions, and feel free to critique it. Feel free to tell me if you think it's not going to work from a human rights lens, and then of course, explore other recommendations. So the WHO released this guidance, and they released 6 principles to ensure that anyone who's working in AI for health, you must ensure these 6 principles are complied with. The first is you must protect human autonomy. So machine autonomy must not undermine human autonomy. It means that human beings should be in full control of healthcare systems and not machines. Second is promoting human well-being and safety and public interest. The rule, AI technology should not harm people. And also, AI systems have the duty, they owe human beings the duty to warn us where they might be biased or where harm might arise. The third principle is ensuring transparency, explainability, and intelligibility. The explainability part is difficult because not all AI systems can explain how they came to their results, but it's one of the principles. There's also the principle of fostering responsibility and accountability, which is very clear, but in that document, they talk about human beings need to be assured of a human warranty. They call it the human warranty in health AI systems. And of course, ensuring inclusiveness and equity, which is a given. And then they talk about the need to promote AI that is responsive, that is responsible, that is sustainable, in a ways that, they can always go back to the drawing board and, make it possible. So these six principles are the global standard from the WHO. In terms of from law and regulatory response, I think these are some of the legal responses that we might tap into when we're dealing with bias in health AI. The first is damages, right? So damages are pretty much a sum of money the law imposes on you when you breach someone's right or you violate someone's right. So it could be compensatory or for the harm that you face due to a biased system, or it could be punitive to prevent such biases from, from ever reoccurring. So damages already exist. There's also the issue of product liability and strict liability within some of the jurisdictions. So, when a person sues another person for a cause of action, the person needs to prove some form of like negligence. You must prove some causation, and that led to a damage that you're facing. But certain AI companies and manufacturers in healthcare, in some jurisdictions, for example, they say, look, if an AI system goes biased and affects someone's life, they don't want to hear about negligence. You don't need to prove anything. It's going to be strict liability. In the same way people look at like chemicals or flammables or like owning wild animals. If anything the animal does to a human being, if you're keeping a tiger, we're not going to explain like, oh, the person triggered the tiger. It's like you take strict liability. In some countries that works. So people are using that framework for for AI systems. In the EU and in the US, there's this debate about what is considered medical software, what is considered medical device, because strict liability can be imposed where harm from a bias system occurs, even where there is no recklessness or intent to harm. There's also the issue of no fault, no liability compensation funds. In New Zealand, for example, a patient who seeks compensation for medical injuries can do that through a no fault, no liability scheme, meaning you're not saying the hospital is at fault. You're not saying the people who created the AI system is at fault. The government will just give you a funded compensation. And then, of course, you can't seek damages and all. So there are so many ideas around some of this. And then, of course, there is issues around preemption laws. There are issues around data protection laws and guidelines, which are very important. Like there is the recent UNESCO one, which was released on UNESCO principles on AI, the WHO's Astana Declaration on the use of digital technology. There are some bioethical specific, I'll call them soft laws. They're like guidelines that help people in terms of how do you develop systems that will prevent bias. And then, of course, there's the talk around government co-regulation with private sector. Some of these are legal responses to bias in AI. From a technical point, there are other avenues by which we can prevent or limit bias. One is counteraction, which is pretty much a clinician literally going through the process of where they've developed or how they've developed like a system, so they can use tools like clinician decision support systems. They can use multidisciplinary data science teams, or like I said earlier, they could have like data triangulation. There's so many ways that they can do that. Other control mechanisms, the very popular one we hear in the field of AI is human in the loop, making a human decision maker as a caveat. But there's a lot of critique around human in the loop. We can come back to that. I believe the AI should be in the loop while the humans should be the ones manning the system, not the AI systems manning and then humans in the loop. There's also literature around humans being lost in the loop. But anyway, that's also a technological solution. And then, of course, the need for affirmative data and reverse engineering, which is the use of like preferential or randomized data instead of just observational data. And of course, there are bias prediction models and sensitivity checks that we can deploy. So to the final part of my presentation, my 7 propositions for how we can use a human rights lens to tackle bias in AI. Why am I proposing a human rights lens? I am doing this because human rights actually provide a common language to frame harms and to offer clear parameters. Also, we have a common language when it comes to framing harm that affects people. There are specific human rights principles that addresses issues of discrimination, marginalization, and even the digital divide that could result from biased AI systems. More importantly, we do have human rights impact assessments for AI health systems that can help provide independent oversight and also help with effective remedies in terms of ensuring prevention, redress, or a non-occurrence of some of these harms. So my first proposition is not pretty much me. Other people have talked about the need for a moratorium on AI systems that are high human risk. So in September 2021, the UN High Commissioner for Human Rights says, let's place an embargo on every AI system that could result to the death of a person. So if it's going to affect the enjoyment of a right to health, can we hold on until it's approved and tested in such a way that the risk is mitigated? So that's one. Second would be a right to contest bias. People should have a right to say, I think this AI system was biased towards me. I'm not sure, but let me contest it, or let me request for a meaningful explanation as to why it treated me this way, or why it took me out, or why I was not able to access certain things, right? Going back to the fourth point on debiasing orders, which is what the presenter earlier talked about, rejiggering, like rejigger the algorithm. So you can go back to the drawing board. Like, for example, Google has had to do something called algorithmic hygiene, whereby they rolled out debiasing initiatives, to ensure that, okay, go back to the system and try to see how you can remedy the bias in those systems to prevent the harm. You can keep reducing. You can keep doing this as some algorithmic procedure. The fifth proposition I'm making is about a human rights algorithmic impact assessment. And there's some examples for that. For example, in 2019, 2 senators in the US co-sponsored what they call the Algorithmic Accountability Act, which requires AI companies that work in the health sector to adjust their flawed algorithms whenever there's an inaccurate report or a biased outcome that would affect like people and stuff. I think the EU Act also touches a bit on this. The EU AI Act does the same. Then the sixth would be giving patients the right to be forgotten from AI for health systems. So because certain people would not like their data or the way they've been treated by an AI system, they don't want that recorded. So very cumbersome to the right to be forgotten, which is in the GDPR. The right to have AI systems delete or erase your entire data is something I think citizens or people should have the right access to. And the third one is much more maybe like a much more academic one. Sorry, the last one I mean. It's a third world approach to harmonizing ethical standards when it comes to AI for health. I think if we keep thinking about a decolonized harmonization of regulatory standards that is pro-poor and ensures that all countries, including countries in the third world, can benefit from rigorous testing, from transparent communication, not just go to African countries and get their data, but can African countries also monitor these AI systems for the health performance? I think these are some of the ways or some approaches that I think can help mitigate bias in the system. In conclusion, there are other recommendations as well. We still need to, I always say the best AI in some regard is no AI. If we don't upskill healthcare workers and physicians to understand that it's a computer, it could be like the pre-computer age, the skill sets and the ethical values that we upheld needs to uphold, and so we need to upskill. Also, I think programmers need to think about research and development, right? And then some non-techno solutionist interventions. For example, we still need diversity in medical schools. We still need diversity in nursing practices. We still need diversity in including or inclusive AI design teams, in co-production, very important. And then, of course, there is the notion of incentivizing developers to, I know getting a more representative data takes time, but it will incentivize. Like I think the US Food and Drug Administration has one. They have like a pre-certification program where they incentivize, so we can incentivize systems that do not have as much biased outcomes from their AI systems. So thank you very much for your rapt attention. Thank you for the time and for the engagement. I look forward to your questions, if any, and I can see Erica is back.
I've actually been here listening very intently. Thank you so much, Jake, for that very thought-provoking and detailed and clear presentation. You covered a lot of ground and many intersecting themes. I have lots of questions, but we actually have quite a few questions from our participants. So I'd like to go to those first, and I will circle back with a couple of questions of my own. So one of our participants, you talked about this around the issue of bias. And so one of our participants was hoping if you could elaborate a little bit more about how might health surveillance systems be biased. Perhaps you might have an example that you'd like to share. Thanks.
Yeah, so there are various ways. The same way regular health AI systems are biased, they could also affect. Again, when we talk about health AI systems, I want you to remove your mind from systems being used in hospitals. Think about your wristwatch, for example. Think about, sometimes we've seen issues whereby health insurance companies are interested in your spending habits. And you might be affected if you go to places like, I don't know why people think Walmart is cheap. It's not. But like if you shop at Walmart and McDonald's, your health insurance company is likely to flag you as someone who might in the future have like a big health issue. So health surveillance systems are not very much different from like other AI systems being used outside the healthcare setting. So the same way they can be biased in terms of how they are trained, how they are deployed, and even how they're interoperable from within health settings to out of health settings, like some of the AI examples I shared with you. These are the various ways they can be biased in their use, in their training, and in their deployment.
Great, thank you. So maybe just picking up on that, but more in terms of some of the tools, right? that you might propose. So what, can you give us some examples of checklists or frameworks that you would propose for monitoring AI bias in the field of healthcare? You talked, actually, I think this was a question that came maybe a bit earlier in your talk. So you certainly shared, I think, some propositions, and you spoke about that major report back in 2021 that the WHO led. Are there any examples you want to share in response to that question? Any tools or frameworks? And that's what they are, but they need humans to deploy them. They're just tools, and so not magic bullets necessarily.
Absolutely. There are some tools. Some of them are more like technical. Some are more, I think the biggest tool is actually being able to constantly put your system on the evaluation block, to constantly ask, do we have enough data? Is it very representative? The story I shared with you, they had over 1 million data entries, but the system still read me. It didn't read me as Black because they didn't have enough Black people. There's something called the use of counterfactuals, which is pretty much where you're going contrary to the fact. You know fully well that certain people in history would enjoy certain privilege. Like if you take the world as it is, it's not equitable, right? So when you do a counterfactual, it's actually a technological process. You're trying to modify the system as it is. Like, how do we ensure that even though in real life certain people face more difficulty to access medical care, but when they use this system, it would give them like a little upper hand in terms of how to do that. So you would almost like go against the norm to ensure that level of representativeness. Even though you don't have Black people in your community or people who are living with disabilities, you need to think about, some of those. We can talk a lot more about what a human in the loop does. I think that's another.
Yeah, and I was going to say, it sounds like also it's around the ethical design, right, from the get-go, because you don't want to wait until those harmful effects are detected downstream when things have been so baked in that at times there is a disincentive to dial it back, right? So it needs to be kind of prospectively.
Absolutely. So there's a lot of that. And the thing is, the last thing I would say is no one is expecting all health AI systems to be to treat everyone in such excellent disposition. But if we know that every 6 months or every 2 years, we go back, we do reviews, we do interviews, we carry out to see how have these AI systems treated women and how did they respond to it versus how did children, it needs to be it needs to be co-productive. In the theory, we talk about the theory of generativity, right? It needs to constantly be generative. So those are some of the tools, but more importantly, it requires the people who use the system and people who develop the system to think in the way that we're thinking.
Yeah, and I think many of the examples you gave also really call upon us to create interdisciplinary processes because, those who are thinking about the technology are not necessarily thinking about the bioethical or legal implications. And
right.
So creating those spaces for that kind of reflection seems really, really critical. I want to take you back. I'm sort of taking these questions in the order they were shared with us. And so this is going back to earlier in your presentation, but you gave a very, I think, stark example about, an example that occurred in Uganda. And the participant was asking how or why did they just remove the files? Was it because in Uganda or China, doctors just stopped treating people who weren't straight? So they were being biased on the basis of their sexual orientation. Could you sort of give us a little bit more context for that example?
The good thing was we pointed out to them why that was an issue and they quickly removed it. But the reason why they did that was because of the legal status for sexual minorities in Uganda. Uganda is not very friendly when it comes to LGBT individuals. So they bought the technology from a country that sort of recognizes queer people, but they did not suit it for the jurisdiction where they were using the technology. So where if you say, oh, I'm a trans person, it's important for your doctor to know so they can give you care that you deserve. In a country like Uganda, that is telling them we don't want to have anything it was disadvantageous to that community. So we had to tell them, why don't you remove it as a question? Why don't you don't add that in there? Although tons of people have already been discriminated, it just deleted them from the system. It was for triage purposes, to get people into line of who to see and the times they can come into the clinic. So, and again, this is not just about sexual orientation, but let's think about the various ways that AI systems can disadvantage certain people, including people who are not, who don't speak English or French, or people who are not literate, or people who are not technologically savvy. So these are, again, it requires that rethinking and constantly engaging about who are we not including, who is not using the system, who does the system benefit or not benefit.
Yeah, I think your example highlights also the great responsibility that comes with collecting certain information at certain stages in the process and how it can be misused, like in the case that you just highlighted. Yeah, thanks for sharing that. One other participant was wondering about how do we go about ensuring the equitable use of AI among healthcare providers? How can current or future education curricula address this? So we, of course, likely have many students, faculty joining us, out there in the vacuum. We don't see them, but my hunch is that, we have people who are playing a role in education, structuring it. Any advice around that?
Absolutely. I think a lot of healthcare practitioners get to understand the use of AI maybe when they're at their jobs, or there's this new device that we've installed on floor 7 now. I'll have a training about it. I think it needs to start in the classrooms. I think, yes, our healthcare providers, nurses, doctors, they don't need to know exactly how the entire system works. We don't need everyone to know how to code, but we need them to understand how the systems were created such that they don't rely on it this is whatever it says, it's yes and amen, it knows better than I do. No, it can be interrogated. So we've seen in X-ray scans that AI systems do it 100 times better than human beings do it, but it doesn't mean that human beings cannot evaluate. So one of the things that people talk about, ChatGPT, amazing technology, but when you ask ChatGPT certain medical questions, we still need human experts to verify that information. So 2 things I would say is we need to talk about AI systems in classrooms, not only in the techno solution is hooray, AI has done this, but hey, AI can be biased, and the onus rests on you as the expert to actually interrogate that, that medical AI system. So we need to see more of this in class, but also the upskilling is important. And I think there's no better time than now to reiterate bioethical principles, the values of do no harm, and ensuring that technology serves the people and does not harm. Like I said, sometimes the best AI is no AI. If the best care we receive are still from human beings and not robots. So we're not there yet, but that diversity in school, diversity in inclusive design teams, and of course the curriculum needs to reflect where and what we see today.
Yeah, no, absolutely. And, it makes me think, I really liked your point about thinking about training the next generation, but also the upskilling point about those who are in practice and also in policy roles, making decisions about potential impact of scaling up these technologies to make decisions that affect societal's, decision making. And, we certainly saw that on a grand scale during COVID.
Yeah.
Wondered, actually, I'll sneak in a question of my own. I was wondering if you talked about a few, but I know in some parts of the world, AI technologies were certainly used to conduct surveillance in the context of lockdowns and tracking people's movements, because, especially in the early months of the pandemic, there were so many unknowns. We didn't have a vaccine. But yeah, we saw that come up in waves in different regimes, I'll say, right. Political regimes. So just wondered if you had some examples that you've come across, any lessons learned from that.
Yeah, so many examples. I mean, at Academic, we have Canadian experts who are helping a lot of African countries with using AI for like pandemic preparedness.
Mhm.
Where we're dealing with some with malaria, with like monkeypox and the rest, and we noticed that some of these like people are using AI systems on people without letting them know that they are being monitored or tracked. So there's a huge biosurveillance issue, which is why I think the onus rests on the people who are powerful, the funders, for example, the people who are deploying. You need to ask questions about what are the other implications of this technology and what are the various ways that we might be affecting certain people's fundamental rights, which is why I talked about the need to tell people like, hey, you don't have to comply with the use of this technology. You don't want to use a gadget. You want to talk to a person. We have that available. Also, like, do you want all your information erased from this system? Very important conversation. So the conversation should be, that's why I always think about like a human right lens. Let's think about autonomy. And at the JCB, there's a lot of talk, there's a lot of literature around some of the ethical values of autonomy and people being fully informed as to where their data is going. I will end with this. We live in a time of dataism. I know we've heard it a lot, where like data is the ultimate. Everything the data says is it, but data is not powerful without its attachment to people. People produce that data. That data is used on people. And so we must prioritize people over the technology every single time.
Yeah, and I mean, data is not knowledge, but when it does become knowledge and it's misused against people, then I think this is where, another ethical principle comes to mind, which is the idea of reciprocity as well. So if we're going to extract this data from people, what are they getting in return? And we don't always. That doesn't always happen. And it comes from a place, I think, of people having a better understanding of what is and isn't being collected on them and on their health and on their behaviors and their movements. Including how to use your own cell phone, because things that are being, tracked without our knowledge if we're not fully aware. One of our participants, I know you touched on this, but I think it merits coming back because this is, I think, a common point of confusion. So in the health and healthcare area, and you made this point, but maybe you could use an example to illustrate the answer to this question, which is, would the bias come from the data that was used to train the algorithm or from the algorithm itself? So I think you touched on this, but you had to go over that fairly quickly. Would you mind just elaborating on that? That was just a question from one of our participants, because I think that's quite fundamental.
Absolutely. It's both. The bias can come from the data that is used to train the AI system. It could also come from, the algorithm itself, because a lot of the AI algorithms used in healthcare are actually like machine learning algorithms, meaning that when we talk about machine learning, is a technique that enables the computer system to learn and make predictions based on historical data. So beyond the data that it has, it can function in a way that it trains itself, it produces new information, or it analyzes data or some analytical modeling in a way that it could suggest something that is pretty much not as outside the data itself. So yes, on both levels, it could be because of the data that it was trained on. It could also be the way that the algorithms are designed, right? But more importantly, so at every level, there's an opportunity for bias to creep in, and at every level, there's an opportunity to address the bias. So even when you had a very, very brilliant system that they used with Opus Health, the fact that they used a cost prediction analysis. So in the data that they got, they were like, let's look at the cost. They didn't look at the biophysical data. They did not look at the historical data in terms of like use of AI. Like they just used cost. And that was a problem. So even if we have a very good data that is like interoperable, it's very well refined, like the way it's used, is very important. And to address your point, Erica, for third world countries, we want our data to be used. We want, please take our data, because we want the systems to be reflective of us. But like you said, are we going to benefit from these AI systems? Like, are you just using our data to train your systems and then, okay, we never get to engage with it. We never get to enjoy some of the progress you're making. So beyond ensuring that our data sets are representative in these AI systems, we also want to participate. Let's tell you where we would like the AI systems to work. I'll give an example. During COVID, most of the funding on AI healthcare went into like really fancy brain development, some really tech stuff. But there is not a single AI system that deals with issues of sickle cell. And sickle cell is a big issue in like sub-Saharan Africa, but because it's only issues that people from where I'm from deal with, no one thinks it's important. Malaria is still the biggest killer of people in Nigeria, but we can spend billions on like building ChatGPT and seeing like what that future holds. So there needs to be some consideration for people, for environment, and I think we cannot advance with artificial intelligence if we do not have a very robust engagement beyond jurisdictions and beyond various systems.
Yeah, no, and I think I really like how you sort of link this to, what constitutes a priority in health, right? And the AI follows those priorities that then leave a number of neglected tropical diseases, for example, behind because they affect, it's an othering of a whole continent that actually occurs that AI can perpetuate, but not on its own. It's partly what gets prioritized in global priority setting circles. Yeah, it's a great point. How are you doing here? I know it's like, here's one more question.
I'm good.
But I think it's a sign of a fantastic talk that we've gotten lots of questions. One thing that hasn't come up that I think is really critical that one of our participants asked was, and we certainly hear a lot about data systems being hacked, et cetera. So how do you make these systems secure so that we protect patient data, whether it's on their physical or mental health? I think is not unique to this topic alone, is a major issue. So there are lots of mechanisms in place to ensure privacy and confidentiality, but the whole security of systems, what thought has been given in this space to security?
Yeah, that's a very important question, and we really haven't thought about that in terms of like the hacking and the rest. So, from a human rights perspective, there's a lot around data anonymization to ensure that even where a system is hacked and people's data is taken, they just have numbers like 21372. They don't know, they can't associate it with certain individuals, even though that's a bit foolproof sometimes, because with a lot more metadata and other information around certain, you can actually maybe figure out who a person is. So data security is a huge one. One of the things that a lot of activists are proposing is that if you're going to create, because there's so many AI systems in health, around like what is your data security framework? How are you preserving, saving this data? Or how are you even deleting it? Like, how do you obtain it? How do you store it? And is it anonymized? And if so, how long is it going to be there before it's deleted? So again, we can talk about all the things, the small prints you look through and just click, yes, I agree. And problems with that. But in those agreements, you're going to find where they say, should we need to use your data? And sometimes when it comes to healthcare settings, people need care. Like, they're not going to start negotiating, what if I don't disagree, or what, like, so it's the onus on the regulator. The regulators and our bioethics professionals like you, Erica, need to be the ones to say, hey, okay, these systems need to think about security and need to think about like protecting people's data, because people's data is connected to their lives. So we haven't really, there's a lot we haven't touched when it comes to AI. It's still pretty new. And unfortunately, maybe with some of these issues coming through, we will be able to rethink and like try to make edits, but we're still starting. It's still a very nascent area.
Yeah, no, absolutely. One other question that I think your propositions kind of take us there, and some of the reports that are coming out around guidance. And so one of our participants, given our increasingly globalized sharing of knowledge, tools, products, there's a real need for international multilateral principles and agreement. And I think there are efforts afoot, but that of course comes with some complications. And I'm not a lawyer, but I also know that while we have international covenants And as your example suggests, even in the Canadian context, and then we've got some Canadian, and then in Canada, we have our wonderful FPT sort of relationship. So it gets more and more diffuse, and that global arena where we're trying to come up with some guidance and agreement isn't, I think, doesn't have the stickiness of legal, enshrined legislations, unlike at the national or subnational level. So there you talked about soft laws. I would just add to this question, the question I was going to ask, which is a point I didn't hear you speak, but you spoke about it. Maybe I didn't hear you use the word governance. So the global governance and how that applies to AI. So there's lots of opportunity for creating guidance. And I think you've alluded to some of them, but maybe you'd like to comment on, where are we at with that and where do we need to go? I think your propositions are taking us in that direction. Certainly other reports have, but they're just propositions, they're just reports. Declarations. This is not unique to this topic, by the way. I don't mean to say it. So where do you think we need to go to really advance the action, equitable action?
Yeah, the point you make is very important. A lot of multilateral principles don't have enforcement teeth. So you can't really you flouted this principle of the WHO, I'm going to take you to court. No, it's a principle, it's a guideline. It's so whilst they may be soft, one value that they have is they actually do some form of norm standard setting. So at least people who are developing or people know that this is the standard. Their standards of fairness, reliability, explainability. These are standards that are actually set up by the WHO, and WHO does have some influence, but it does not remove the need for domestic legislation, whereby when harms from AI systems occur, it's not just about, you flatter my privacy or you didn't do the right thing, but what happens to me then? Where is the remedy? And I think there's some need for complementarity. So it doesn't mean that, because there are international principles, then there's no need for domestic ones. I think there's a need for both, because for some countries like Canada, who's advanced in this area, some other countries don't care about human rights. They're just like, well, we're thinking about, making our health sector make money. Who cares about data protection and data security? No. So not all countries are thinking in that regard. So it's important that these international principles like the UNESCO one, the WHO guidelines, the Astana Declaration, like the data security oath, there's just so many documents that you can rely on. Yes, there may be many, but we still need them. So we can say, hey, you're not complying to international standards. So you are below the par, but it's not enough. We need local legislation. We need seminars like the JCB series where we can share knowledge and say, hey, these are the gaps and these I think where we need to improve upon.
Yeah, no, I think it's a great point. And I think that complementarity between international, national, subnational, sometimes I feel it's a game of parallel play, but not necessarily coherence and complementarity.
You're right.
I know we're almost at time, but I'm just going to share two questions with you. First of all, one of our participants asked to be named, Obina Ede, who really commended you for sharing a lot of good stuff in your presentation, Jake, and thanks you for helping to simplify the concepts and tying them together. In tackling bias, are we not expecting the developers to see the future and do the impossible? There are characteristics that don't exist today, but may become more apparent in the future. We're not within the knowledge of the developers. And so, from their perspective, they're potentially, they want to do good, not to blame them for doing things. There are things that they can't necessarily predict at this stage in time. So how do we advise them in that situation? And if, so maybe you just want to comment on that briefly. And then if we have time, if we can hang on for a couple of minutes, we have one more question that I would love to get to as well. So any thoughts on the role of the developer?
Yeah, I think sometimes we assume that all developers want to do good. Yeah. Maybe they want to make money.
Right?
Yeah, we don't know. So I mean, we have to judge them by the output of their work. If your work is biased to indigenous people or to women or people who are living with disabilities, then we can't rely on intent. Intent is not enough. is your product delivering? And we're not saying, I think where there's technology is advancing what is already existent. The do no harm principle is already there. Harm is harm. Harm is not new. So if your technology cannot make things better, it should not make things worse. And I think these are bioethical principles that technologists need to know. Technologists should be getting a program at the U of T, at the Center for Bioethics. They need to be engaging with the Center for Global Health. Like, technologists need to literally go to school and study ethics and study you're going to produce a technology that healthcare people are going to use. But you spent your entire time doing computer science and engineering. Great. But now you're going to do something within the health sector. You need to understand the principles at the very least. So it's not like we're really, really being really soft on the developers. Like, I don't think we're treating them the way we would treat people in other sectors. And I know tech is pretty much like privileged, but it's not. They need to do the work. If you're going to create a system for a sector, you need to understand the sector and try to make it better, not worse. These are very basic principles, and we'll have to keep pushing that on them because it's there. We are doing our part as lawyers, for example. We're trying to see how we can mitigate harm and ensure that people who cause harm, suffer for their consequences. So we are doing our job. They need to do their job, and professors like Erica too, they're doing their job by educating people and engaging in seminars like this. They need to do their job as well, because they're the ones making billions of dollars when a hospital gets to use their system and 5,000 patients get to use it. Woo! They're rich for life. So with that richness comes responsibility.
Yeah, no, I think well said. And it speaks to, I think, one of the recommendations towards the end of your presentation about what are the incentives that are actually encouraging certain behaviors, and why should they not be held to the same account of principles that all of us are, right? Or the rest of us. I know we're about to end, but I really, really do want to ask this question because I think it's really interesting, because right now we haven't had a chance to really talk about the who behind the data. And so that's patients, communities, vulnerable populations, people who are discriminated against because of their race, ethnicity, gender, sexual orientation. And one of the participants mentioned that, there's been a lot of effort to try to change the language around how we refer to patients as partners. And the use of the term catastrophizing, the ideas around neurotic and somatic symptoms, like how patients are come to be described. So I guess the question is really, is AI bringing this up to the surface again? Not that changing the language is enough, but how you, and we were talking about this earlier, how you can other entire parts of the world, and by ignoring problems that only face them. Are we doing the same thing in the AI space? Any lasting thoughts? And that will be the last question, and then we'll wrap it up.
Great. I would say that the fourth industrial revolution has shifted the role people play within the medical setting. People are not just patients, they're actually partners. They're actually advancing the health system. And I'll give an example. There was a monkeypox outbreak sometime last year that predominantly affected gay men. The response with certain communities, so LGBT communities who came together to respond to it, informed the health, the biggest experts on human beings are the human beings themselves. But these people who were suffering from monkeypox actually did help in curbing it from becoming like a pandemic, because they knew how to engage with each other. They used their network for socializing. They shared information. They submitted themselves for tests, and it's engaged rapid response. So patients, by using AI systems, are contributing to the data sets. They're helping improve the technology. So they're not just seeking help, they're actually partners. And I think they must be regarded as that and respected as that, by ensuring that they are on the same footing with, just as you would recognize a doctor or a nurse. A patient is not just somebody who you're giving care to. The patient is also a partner in their own care, but also in advancing the system. So I think the monkeypox example was a great one. Again, kudos to a marginalized community, but in terms of the way they've navigated in the past, they use the same to, to inform and help better the treatment for themselves. And I think other communities also benefited from it. So in closing, I want to say a very big thank you to Professor Erica. Thank you so much for this great moderation. And I'm really excited about this. Thanks for having me here. Thanks to Professor Jay Shore, Vadim Levin, Terry Yuen, and to everyone at the Center for Global Health and everyone at the JCB. More importantly, thanks to everyone who stayed, who asked questions. I'm really grateful. I think this is such a great series by providing a free platform for very important bioethics discussion. So thank you.
Well, thank you, Jake, for spending this hour and a half. It really whipped by, and I think we could still stay and engage in discussion. I think we've scratched the surface. I want to thank all our participants for their very thoughtful questions. But it is time to draw a close. And before I thank you properly, just have a couple of brief announcements to make. So the news about the next JCB seminar will be posted in the upcoming newsletter, so look out for that. And if you want to sign up or receive email reminders about these seminars, please email jcb.info@utoronto.ca, and Terry will just put that in the chat. And again, a huge thanks, Jake, on behalf of all of us. Thank you so much for your presentation and your insights, and really, really appreciate your thoughtful responses and taking the time out of your busy schedule for engaging in this conversation. So thank you again, and have a good evening and night, everyone. Take care.
Au revoir. Bye.
Au revoir.